Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 538 of our pharmacotherapy series, which majors in anxiety disorders. The next case reads: RCG is a 25-year-old woman whose husband complains she spends 1.5 hours a day cleaning the stove and takes 4 showers each day. The unusual behavior began about 1 year ago after the birth of their son, but has continued to worsen, and RCG's husband states that he cannot deal with her odd habits any longer. RCG recently lost her job as a secretary because of tardiness. It took her 3 hours to get ready for work, and spending too much time away from her desk in the ladies' room. RCG admits that it is silly, but she has irresistible urges to make sure both she and her surroundings are completely free of germs so her child will not get sick. She also confines herself to one floor of their 3-level house, because she is afraid she will fall down the stairs while carrying her son. RCG also states that she constantly has what-if thoughts about horrible things happening to her family, which are very disturbing. The physician's diagnosis is obsessive-compulsive disorder, abbreviated as OCD. What clinical features of obsessive-compulsive disorder does RCG display, and how can her symptoms be objectively evaluated? RCG displays many characteristic symptoms of obsessive-compulsive disorder. The most commonly encountered clinical presentation of obsessive-compulsive disorder involves excessive fear of contamination with dirt, germs, or toxins, and repeated washing of hands or cleaning objects or surroundings. These persons also typically avoid touching possibly dirty objects, e.g., doorknobs, money, or shaking hands with people. Another common clinical presentation of obsessive-compulsive disorder is the patient with pathologic doubt who constantly worries something bad will happen because of his or her negligence. Individuals can be afraid they have failed to lock the door, turn off the stove, shut the refrigerator door, or secure the medicine cabinet from children. As a result, they continuously check and recheck their actions. RCG displays obsessions of contamination and pathologic doubt, and compulsions of excessive cleaning and washing. These symptoms are time-consuming, cause significant distress, and have led to her unemployment and marital difficulties. As seen in this case, most persons present with a mixture of various obsessions and compulsions. RCG also realizes her thoughts and behaviors are silly, which most often is the case in obsessive-compulsive disorder. This case also illustrates the onset of obsessive-compulsive disorder during times of stressful or significant life events. Pregnancy, death of a relative, and marital discord have been identified as precipitating factors in the onset of obsessive-compulsive disorder. On assessment, RCG's Yale-Brown Obsessive-Compulsive Scale, abbreviated as YBOCS score, is found to be 33. Her physician prescribes fluvoxamine and instructs RCG to take 100 mg every morning for 1 week and then 200 mg every morning thereafter. He also refers RCG to a psychologist to receive cognitive behavioral therapy. So my next question to you reads: is this initial choice of therapy appropriate? We will begin with selective serotonin reuptake inhibitors. Regarding selection and dosing, selective serotonin reuptake inhibitors such as fluvoxamine are considered the best choice of initial pharmacotherapy for obsessive-compulsive disorder. The primary differences between selective serotonin reuptake inhibitors involve pharmacokinetic properties and potential for drug interactions. Because there are no overall differences in selective serotonin reuptake inhibitor efficacy, fluvoxamine is a suitable selection for RCG. However, the prescribed dosing instructions for RCG are not appropriate. The initial recommended dosage for fluvoxamine in adults is 50 mg per day, and 25 mg in children, and it is best taken in the evening because it tends to be sedating. Using higher than necessary dosages can increase both adverse effects and medication costs, and these factors can lead to early termination of therapy. The dosage can be increased by 50 mg increments every 3 to 4 days according to patient tolerability, up to the initial targeted dose of 200 mg per day and a maximum of 300 mg per day. Daily doses exceeding 100 mg should be given in 2 divided doses if once daily dosing is not well tolerated. We will now briefly consider adjunctive cognitive behavioral therapy. RCG's Yale-Brown Obsessive-Compulsive Scale score of 33 indicates a moderate to severe symptom severity, which supports using a combined treatment approach. The overall efficacy of these non-pharmacologic treatments is estimated to be 50% to 70% when used alone, and their use to complement pharmacotherapy is considered vital. For RCG, exposure and response prevention therapy might involve covering her hands with dirt and not allowing her to wash them for a certain time period. These behavioral techniques cause extreme anxiety and discomfort, which often lead to dropout from therapy or non-compliance with homework assignments, which involve continuation of the therapy principles outside the clinical setting, but are highly effective if the patient can adhere to treatment. The next question reads: what patient counseling information should be provided to RCG in conjunction with the prescribed treatments? All obsessive-compulsive disorder patients beginning treatment should be counseled that medication response occurs gradually and several weeks may elapse before beneficial effects become noticeable. It is important to emphasize that maximal response may take 3 months or longer and complete elimination of all symptoms is unlikely. Inform patients that a variety of other medications exist for those who do not respond adequately to an initial trial. RCG should be educated about possible fluvoxamine side effects, including nausea, sedation or insomnia, and headache. Medication should be taken with food to decrease these effects. Side effects are most common during the initial weeks of therapy, are usually dose-related, and often subside with continued treatment. Patients should be encouraged to report any problems to their treatment provider. The importance of adhering to prescribed therapies, both pharmacologic and behavioral, should also be stressed. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 539.